Good evening. My name is Catherine Lampy, and I'm the director of the SVS Foundation. I'm pleased to welcome you to our new industry-led vascular innovation webinar series. These webinars represent an exciting opportunity to strengthen our collaboration with industry partners who share our mission, optimizing vascular health for patients and the public through research, education, and community health initiatives. Through sessions like this, our goal is to connect vascular specialists with timely, high-quality education on emerging therapies and technologies. We're proud to partner with Boston Scientific for tonight's inaugural webinar, From Data to Decisions, Optimizing Outcomes in PAD and CLI with Eluvia DES. This program brings together leading experts to share the latest clinical data, real-world insights, and case-based discussions that are shaping the future of endovascular care. Now it's my pleasure to introduce tonight's esteemed faculty that will join us for this webinar. Dr. Sonia Noor from the University of Buffalo, Dr. Anita Dua from Massachusetts General and Harvard Medical, and Dr. Peter Schneider from the University of California, San Francisco. Thank you all again for joining us, and I'll turn it over to Dr. Noor, who will kick off the session.
Thank you, Catherine, and good evening, everyone. Thank you for joining us this evening. We are going to share with you our cases and some data. As you can see, I'm joined by Dr. Anahita Dua and Dr. Peter Schneider. I'm going to kick off the session starting by talking about a case that I had done recently. These are our disclosures. And so the case I'm going to present to you is a patient that I have taken care of who comes in this time with, he's a 69-year-old white male with increasing claudication bilaterally, but more on the right leg. He's had claudication at that point for about 5 or 6 years, but when I saw him in the clinic at that time, significant disabling claudication, lifestyle limiting claudication. Since we had seen him in the past, he had gone on a guideline-based medical therapy. So he was on a statin, he was on an aspirin, medication for hypertension. Past medical history really was significant for hypertension, MI, pulmonary emphysema, and he was a previous smoker. But this was the first intervention that we were really thinking about doing on him, given his new symptoms. As most vascular surgeons would, we have a vascular lab in our office, and his arterial Dopplers at that time showed an ABI of 0.57 on the right, 0.60 on the left. And once again, lifestyle limiting claudication, pretty disabling for him, and with a failed conservative therapy, unable to do any further exercise. So pretty much our algorithm at that point is to bring the patient in. I don't necessarily do a lot of diagnostic imaging like a CTA or an MRA prior. If I have good femoral pulses, I do pretty much dive into doing a diagnostic angio with the intervention to treat, which is what I did that day. As you can see here, patient had a left common femoral artery access, went up and over, finished our diagnostic aortogram, selectively cannulated the left common femoral artery. And as you can see here, you can see a very small nub of the superficial femoral artery. Superficial femoral artery is completely occluded up until the adductor canal area. And then the distal SFA above knee popliteal segment, so P1, P2, P3 are patent. And in the last panel, you can see below knee pop gives you a trifurcation, but the anterior tibial goes on to die in the middle portion of the calf with 2 vessel runoff in the form of a posterior tibial and a tibioperoneal trunk. I didn't really go into the crossing of the occlusion bit, but catheter wire directed, really nothing fancy, to be honest. Took us a few attempts, but catheter wire technique was used, and I was able to cross over, re-enter, confirm that with the angiogram, and then plan to do a pretty straightforward balloon angioplasty. I used 2 6x200 plain balloons, followed by deployment of 2 Eluvia stents. So the CTO length was probably in about the 250 range. So 2 overlapping Eluvia stents. Of course, nailing it proximally is always interesting, but as luck would have it, it did work out that day quite well. So these are my completion angios. Yes, they are running. Okay, so that's your common femoral, and then your SFA. As you can see here, pretty good result in the adductor canal. And then this is, again, your 2 vessel runoff. Anterior tibial goes on to occlude kind of lower down in the leg. So pretty happy with the result. Had to throw in a little Buffalo cheer here. Our Bills are playing this weekend. So it was good. It was a success. Always worth celebrating when we have a success. But part of what we're talking about today is, what is the data that exists out there that helps us make decisions, good clinical decisions for these PAD patients. Eluvia is a drug-eluting device made by Boston Scientific that has been approved since 2018. It's on the Innova stent platform that I was pretty familiar with. I was an Innova stent user amongst other bare metal stents. Eluvia is a little special, I think. It has a polymer matrix on the stent. So it allows a low dose paclitaxel to elute over time, as opposed to a drug coated stent, maybe more like Zilver would be. So Eluvia does have, I think, a pretty good elution profile. It comes in multiple sizes, mostly 6 and 7 in terms of stent diameters, and then anywhere from 40 to 150. So the Eluvia that was used in this patient was 2 6x150s. It does have quite a bit of clinical evidence. Majestic was the trial that actually brought it in, got its FDA approval. Worth mentioning on this slide are probably Imperial, which was a randomized control trial looking at Eluvia and Zilver, which demonstrated superiority in 1-year patency for Eluvia over Zilver. 5-year follow-up has been completed on that. There are a few other registries that we will talk about today, including sports. But these were really the data that was available from a randomized control trial and a registry standpoint, which would be traditional ways that we would look at evaluating new devices that are out there, and certainly Eluvia was one of them. What I would like to share with you today is really what I consider real-world data. I think this is a little bit more realistic for those of us who work not just in a big city or an academic center, but using real-world evidence that's not in a randomized control trial, not necessarily cherry-picked, if you will. So Truveta is a platform like that. The Truveta has been used. This is data that has been collected from 120 million patients over 800 hospitals, 30 hospital systems all over this country. So it's a pretty robust database. It's de-identified electronic health records. And specifically for this data set evaluation, PAD patients undergoing any kind of endovascular femoral-popliteal balloon angioplasty and stent with and without drug elution is what was really identified. And the outcomes were followed to see what is the difference between these two groups of patients in terms of above ankle amputation, readmission within 12 months of the procedure, and then mortality at 30 days and 12 months. So I think it answered some interesting questions for us. So, oops, I went up, sorry. Gotta go back. So the Truveta population that basically mapped out to drug elution and non-drug eluting stents was from a basis of 111,000 down to 49,000. If you mapped it to peripheral arterial disease with the ICD-10, brought it down to 47,000. And then if you specifically looked at drug elution with paclitaxel stents, drug-coated balloons, or femoral-popliteal devices that were used in patients with femoral-popliteal disease that were non-DE, then you came down to about 10,000 patients. So in the Truveta database, if you looked at the 10,000 patients that could be selected for outcomes evaluation, DE device or drug elution device was about 5,318. Non-drug eluting device would be 5,156. So when evaluating these patients, if you look at their demographics, I would say for the most part, it was pretty similar. The things that jumped out was about 40% female, 82% were male. Drug elution was more frequently in white patients, less frequent in Black patients, and DE device was more frequent in Hispanic patients. When you looked at the other comorbidities, I think it's a good comparison or a good data set because I think it's close to real world, close to what you and I would see normally in our clinic, which is about 32% CLTI patients in both groups. And all other comorbidities that you see here, like hypertension, hyperlipidemia, diabetes, were pretty, I think, standard and comparable in both groups. There were about 57% of smokers in this comparison. When you looked at the TRUE-PTX outcomes before propensity score matching, and you looked specifically at above ankle amputation, you will see that there is both less frequent amputations as well as readmissions on the drug-elution arm versus the non-drug-elution arm. And specifically, when you looked at mortality, there was no difference in the 30-day mortality or the 12-month mortality, which, as you know, is kind of a cloud that hangs over us about paclitaxel. So this was something that looked at these patients and did not find a difference in mortality, I think, which is reassuring for those of us who like using paclitaxel-based drug-elution. When you did the propensity score matching and you looked specifically at above knee ankle amputation readmission or readmission due to any other reason, interestingly, the odds ratio, so patients did worse if they did not have drug elution, in which their amputation level was higher, readmission level was higher, and then readmission for any cause, whether it's directly related to the procedure, requiring a secondary procedure, or any other reason. Another way to look at this would be to take this subset and specifically parse out the red box in the lowest part of the screen where it says Eluvia. So if you took this database of 10,000 patients and looked at specifically who received Eluvia compared to non-drug elution, and you looked at propensity score matching in this subset specifically, you see a pretty strong response where the non-DE patients are much more likely, higher odds ratio, to have above knee amputation as well as readmission. And I think for someone like me, that is very reassuring to see that Eluvia tends to do better than other drug elution, but also significantly, you can see there's a difference with non-drug elution database that was looked at here. So I'll pause here for a second before I hand over to Dr. Dua, who's going to present next, to see if we have any questions and if my panel, who I'm co-hosting with, have any questions for me. Thank you again for the opportunity.
Yeah, thanks, Sonia. Hi, this is Peter. I was wondering, this is really interesting data, but on the case, of course, we love cases. I'm wondering, so that was a pretty long occlusion. So 15 years ago, that wouldn't have been a routine case, but now it's probably a routine case for you. And you said you were able to get it with wires and catheters. Was it a looped hydrophilic wire, or how did you end up getting across?
Yeah, so my go-to is honestly a stiff angle glide wire, make a loop, take an 035 Rubicon behind it, and then just kind of make my way down. I try not to go too subintimal. I feel like this centers me a little bit better. Sometimes I'll take the loop out and leave a little bit of the catheter or a little bit of the wire sticking out. And then if it's a smaller vessel, I'll go down to an 014 CTO wire with an 018 catheter, and usually I can get back in.
Yeah.
What do you do?
Well, it's interesting because, we're all trying to figure out where does retrograde access fit. And I've been honestly a little bit reluctant to do a lot of retrograde access in claudicators. I feel like they have a long-term life expectancy. I don't want any undue, risks or complications. So I think, because of that, I'll persist a little bit more from proximal. And the truth is, before retrograde access, we got across a lot of these, 80% of them, sometimes more. So I do what you do. Maybe I persist a little bit more in a claudicator, and I use a looped wire and an angled catheter. And if I can't do it, then I'll do a retrograde if I'm absolutely going to treat. Very interesting. And the other thing I wanted to ask you about was, do you have any tips for when you're putting in your second stent, your more proximally located stent is going to be kind of a long one, of getting the upper end of it to land properly? I struggle with this. Proximal SFA is a weak point. It's a weak point in getting across it, and it's a weak point in getting the stent just right. And I feel like I do better when I put a shorter stent there, and I can kind of gauge the foreshortening a little bit better than I can in a long stent. But what do you do, or do you have any thoughts on that?
No, it's a great question because I think often our occlusion starts just beyond that nub. So you really have to prep that part of the vessel well. So after I've crossed it, I really take some time doing a good balloon angioplasty over there. So I have a really good vessel prep. And you're absolutely right. Stenting and being able to end right at the, as close to the origin of the SFA without crossing over to block the origin of the profunda becomes really, really important. So if you can put a longer stent below and a shorter stent above, I think that definitely helps you, prepares you a little better. But I really, at that point, mag up really well so I can see the entire screen. And I'm really watching my distal, so where it's going to end at the top.
Yeah.
If there's any doubt, honestly, I'll put a third stent in. I'd rather like end a little lower and then put a short focal balloon expandable stent in at the top. I think if you mag up and you prep the vessel really well, I don't think it moves as much. I think you can kind of nail where you're going to be able to end. But if you are going to fudge, I say fudge short and add a third balloon expandable stent at the top.
Yeah, that makes a lot of sense. And if you're going right to the origin, a lot of times you're going to angulate the II,
Oh, the C
et
arm,
cetera,
sure.
so that
Yeah.
you can see
Yeah.
exactly where that point is. And then just like I said, we love the cases, but on the data, it's just so impressive to see the kind of data that we're getting now with, I think you had over 100,000 patients that you initially used to call the right patients from. So that TRUE-PTX data, and it seems like every time I turn around, I hear about a new database that's been accumulating for years, and that then we can go on and learn something from. So I was pretty impressed with that information you presented. So
Thank you. One of the questions that I had for you folks is often I'll hear from my colleagues, they still seem to have a little bit of a preference towards bare metal stenting versus drug-elution. And I use a lot of drug-elution. I'm a believer in drug-elution, and the more data I see, obviously, the better it is. What do you think stops someone, or what encourages someone to say, I'm going to use drug-elution in this case. I'm not going to use drug-elution in this case. Like, what would their reasons be, do you think?
Money. It's always the reason. Whatever other thing that they say is not true. Because at this point with the data, there's really no question. And this data is not new data. This has really been around a long time, in how quickly endovascular stuff moves. I think this has been accepted, and it was scrutinized pretty aggressively after what happened with hormone mortality association. So we know even more so. And then we've also moved away from the endpoints that we used to previously have. Historically, the endpoint was kind of up against an open, great bypass with good outflow with a vein. Oh, I can get 10 years out of it. Why would I do something endo? The answer is because nowadays it's all about healing that wound, and you need 200 days to heal the wound. So you need whatever you do to last at least a year. And there's no question that with using the drug, you get better results, but it is more expensive. And so I do think that there's a lot of argument to be made, especially, a significant proportion of what we do is in the community. It's hard. I'm not saying that they don't want to do the best. I'm just pointing out that it's difficult because of the way that healthcare is structured to be able to really justify it when it's such an increased cost. So sadly, I don't think it's a scientific reason for not using it.
I was going to say there's a question in the chat that I saw while you guys were talking about that. It says Eluvia's smallest diameter is 6 millimeter. The IFU says it can be placed in a 4 millimeter vessel. Are you comfortable with placing an Eluvia in a 4 millimeter SFA, or would you favor a 5 millimeter Silver PTX? What do you guys think?
I've used Eluvia in 4 millimeter vessels. Again, I'm big on vessel prep. I just want to make sure the vessel can handle it. If I'm very concerned about it, I'd rather go with a Ranger. Quite frankly, I'll do a drug coated balloon. I'm not a big believer in silver. I don't like the stent design. I don't know that it has an advantage over Eluvia or the stent itself. What do you guys do?
I agree with you about vessel prep, and I definitely use IVUS. Really, I don't remember the last time I saw a 4 millimeter, a true 4 millimeter SFA. It's one thing to shoot the dye and think it is, but then when you IVUS it, it's always 1 millimeter to 2 millimeters bigger than what you think it's going to be, and that 1-to-1 is important because ultimately the IFU is the key. I'm not doing anything in the POP and TP trauma. I mean, I don't mess with that, but that's a different problem. But certainly in the SFA, I wouldn't have an issue.
Yeah, to me, this is a good question because kind of on the limits of stenting, and I think I generally agree with what you guys are saying. I think when you get into the smaller arteries, a smaller SFA like a 4 mm, I don't think stents do as well in general. So I'm more motivated to do stent avoidance. And in fact, there's some data from Japan from about 2 years ago looking at different diameters, and the patency seems to really fall off when you get below 5 mm. Having said that, a lot of times I'm wrong. And if I IVUS it, it's actually bigger than I thought it was initially. So yeah, I think stent avoidance for the smaller SFAs, but if you have questions about size, I'm much more likely to be interested in IVUS these days to supplement, what I'm getting from angio. So anyway, maybe you should go ahead, Anahita. This is a good discussion, very interesting.
Yeah, this is always the best part, right? Especially after you've had a data dump.
Yeah.
So welcome everyone. Thank you very much for being here. This is so important to the question that was posed earlier, about like why we use certain things, when we use them. Especially nowadays, gone are the days when someone can walk into your office and just say, "Oh, doctor, what do you like?" And you get to just take it. We all suffer our VAC committees and, all these other admins and whatnot that block us from using the right thing. And ultimately, the only sword that you have to get the right thing for your patient is the data. So kudos, of course, to Boston Scientific for doing some of these head-to-head studies. And of course, the whole point of tonight is to, of course, talk about our cases, which are interesting, and have the discussion, but also arm you with the data so that if there's something that you're interested in, you can put together something that can help you take it to the next step. So with that, I'm going to start basically talking about stenting, but specifically the drug-eluting stents, and using them really in long segment SFA lesions, but also in kind of spot stented areas where you need help. And that's the case I'm going to show you here. I really wanted to find something that was like truly real world. Just over the last week, I really could have pulled, 4 cases of here's my SFA, here we got through it, and then we just banged in a bunch of Eluvias, which is what I do. But, there's nothing really to that. I wanted to show you something really complex. So here we have 54-year-old patient who had a severe non-healing wound with really unbearable pain, had been offered an amputation, but again, 54 years old, construction worker, classic, continued smoker, and refused to stop. So that is important. But he was unable to work because of the pain in his foot. And I'm trying to go to the next slide here. Sorry, there we go. This is the wound I want to show you on the foot there. So no maggots or anything yet, but certainly severely necrotic tissue. You're already looking at tendon and maybe like one layer before I would get down to bone. He also had this other odd lesion on the lateral aspect of his calf that I couldn't explain, that had been there for a little bit, and that was after a traumatic incident. So I'm going to show you the CT scan, which is going to go by fast, but essentially everything is occluded. That's the read, all occluded. Starting essentially from the takeoff of the iliac, going down into the femoral where there's some flow, but it's not enough, and then the SFA out. And pretty much beyond that, you can't really even tell, I'm just going to play it over again here, what's going on after, right? So as you can see, a lot of calcium, and this is again on that right side. So significant inflow problem, and I don't know what's going on with his outflow. So in a patient like this, we're vascular, I'm a vascular surgeon, vascular surgeons. This is a person that at the bare minimum needs the scalpel to get the femoral dealt with properly. And then the big debate starts. Is this a person that should get a femdistal bypass, or fem-BK bypass? Because he's 54 years old, you want something durable. He did have vein, okay? So he could have had that. There are a couple things that go into that. Number one, what does the patient want? This guy was cool with anything, so okay with me making the decision. Of course, would have preferred something that was less invasive. But I didn't love that horrible wound on his foot that was chronic, and that could potentially cause an infection. And I needed something quickly to get him good established flow. So what the plan was to do a femoral endarterectomy, essentially, and then go into the iliac and try to recannularize that area, because really the external, and stent that. And I use actually Viabonds in the external and VBXs in the common. And that's my standard covered stents when I'm going up into the abdomen. But then distally, recannulizing his SFA, seeing what his popliteal would be doing, and then ultimately, I was thinking stenting versus balloon angioplasty with drug-coated balloon for his SFA, and then, of course, the wound debridement at the time. So to start out, we got in, we did our femoral end dart. The way I do it is once I do the femoral end dart and I'm actually looking at the open end dart, I take a V18 wire and a CXI, and I'll recannulize right under direct visualization. It's a bit of a pain because the wire is sticking in your face. So I had one going down into the SFA, one going up into the iliac. And it's quite difficult to keep track of them. But the beauty of it is that if you are intraluminal, to the point that was made earlier, and you haven't really dissected anything, you then can stay in that beautiful plane when you put your sheath in, right? Because you can externalize the wire through a micropuncture needle. And it really works well. So then after I had basically gotten wire access on both sides, I went on to put the patch down and then shot my flow. And this is what I saw initially. So as you can see here, flow, and then I'm going to play this again because it's hard to catch right away. Immediately, this huge, oh, I'm so sorry, my son is here. Please excuse me. Baby, you're going to have to go outside or daddy's going to get very angry. Please go outside. Okay, so come here. Sit down on the floor. You can watch YouTube. Go outside. Sorry, guys. I don't know what to tell you. Anyway, so daddy will tell you. So essentially, once you had the popliteal here and then you had that bad lesion, you can see over here that we had a decent AT, and then you had the PT and perineal down here that were being basically fed from this large collateral. But beyond that, we really had no flow, and this was really my big area right behind the knee. So again, somebody that would be potentially good for a bypass. He's got 3 vessels, and that did go to the foot, but nothing that was in line. And again, I was worried about putting a big incision on this guy with a large wound. And that can be debated, and I'm happy to debate that. But ultimately, what I ended up doing was recannulizing and getting into that AT. Interestingly, I don't know if there's something wrong with the patient's anatomy or what it was, and I did not feel that coming retrograde to point out what we talked about earlier was worth it in this guy because there was a lot of operating for him. But we did get into that AT. And then the question was, well, how am I going to maintain this outflow after doing what I had done to the top, which we'll get to in a second. And you can see this huge lesion here, which was really my problem because after doing all the work up top, the last thing I wanted was for everything to go out because I didn't have good inflow. So after recannulizing, and I did use an Eluvia balloon here, I was unable to decide what the next step would be in terms of whether or not I should stent, because once again, it's not a great location, and there's a situation with a large piece of plaque. Now, at the top, I had already recannulized into the iliac. That wasn't too difficult, much easier than the SFA as it typically is. And here, as I mentioned, we just put a Viabond down, and you can see my beautiful arm there. And that was the end of that, beautiful inflow. And then putting a clamp on, decided to move through the next part, which is the leg. So here, as you can see, this whole thing is shredded, right? And I know that I'm giving you the stent talk here, and that was really the next question. This looks horrible. Should I stent now from the takeoff of that SFA all the way down to where? That place where I had that huge chunk of plaque? I don't know. Again, the conversation we just had about the 4 millimeter thing is important because that's pretty tiny. And that area was pretty tiny. Unfortunately, we did not have great arthrectomy tools. Now we have some good stuff, but at the time we didn't. And again, major institution, I am at the Mass General, but we didn't have something great at that time. And the whole debate there is, do you arthrectomize somebody like that and risk embolization when he could, again, just get a bypass? So I was going to be hesitant about that anyway. My whole goal here was I want to just heal this wound. I can always come back and do a bypass now that I've dealt with his inflow. So what I did for this area is I actually just used a flat VCB. And I got a beautiful result actually from that. All the way down though here, I really could not get away with not stenting because again, this inflow was completely shredded and I had that large area of plaque. So I decided at this point that I was going to put an Eluvia down, distal to this. This is that inflow. And put it right in this location against the plaque. I know that someday this guy is going to ultimately need that bypass. He's only 54. He's still a smoker, blah, blah, blah. But for what I needed at that time, nothing could have been better. I got the drug-eluting technology, which means that I'm going to get at least a year, if not 2 years out of this. And I'll get to the data in a moment. And I have the stent in place that's going to allow, and here it is, that's going to allow me to get good flow. And you can see it's not landed in a wonderful location, but it did a really good job with pushing over that plaque for me to give me good inline flow distally. And then I had very brisk flow now down all the way. I told you earlier something was weird about the guy's anatomy. We tried for quite a while to get into what I thought was the TP trunk, but really, without coming from the bottom, it's impossible to really tell. And I did have more than enough outflow at this time to keep open what I had done up top, as you can see here, with decent, again, 3-vessel runoff going all the way down. So at this point, we decided to stop, got him what he needed, and he actually did heal. I just wanted to show you this final, there's that runoff, right? And that was just from what I mentioned up above. And the most important thing is this is where the wound was, right? So I have really nice flow. And that's why I've really gone after that AT out of the vessels, because of course that's the angiosome that feeds that particular location. Always at the top, checking out. I didn't love this, came back with another drug-coated balloon. And had that not done the job, I would have put down a spot Eluvia stent in that location. I have many patients like this, not with the other criteria that you saw here, that I would very freely put Eluvias from the takeoff of the SFA all the way down to about Hunter's Canal. That's what I like to do. That's ideal. If I am going behind the knee, which I really do infrequently, it's usually a Sapera, which I'll put back there. But I have used Eluvias, but I don't think that that's the ideal thing to do. The ideal thing is a stent that has good flexibility, and that is the Sapera. So of course, the goal of this and the reason we made this type of decision making, anything could have been done, was that I didn't want to make the patient worse. I wanted to do something that was not expecting this to last 25 years. I just wanted to last, the patient would heal. And again, he did. And I didn't want to put him through a big bypass, especially if he's not even stopping his smoking. Because at this point, that's not a patient that's going to have a great result. So specifically what I want to talk to you about is the sports study. This is actually a very important study. I would argue, and I'm biased because it's the one I'm telling you about, probably the most important thing we're going to talk about today, because this data is really interesting. This is essentially comparing in a prospective randomized 1-to-1-to-1 study using drug-coated balloons, bare metal stents, or drug-coated stents, 1-to-1-to-1, 74 to 76 patients per arm. Really well done. And this is what I want to draw your attention to. Long lesions. Why does that matter? Because historically, when we see studies like this, we see the cherry picking, short little lesions, which frankly, you got to argue, like, do they need stents at all? But the long lesions, you really do, because you likely will have multiple areas of coming in and out of dissection planes, like you just saw what I showed you in that patient. And so having a long lesion is important to really determine whether or not a stent versus a drug-coated balloon versus the bare metal stents, which again, to Dr. Noor's point earlier, a lot of people use, what's truly better? Well, I mean, I'll tell you the answer. The answer is absolutely drug-coated stents. And not better in just one area, better across the board. Again, I'll show you a few things, but before I jump into that, I just want to show you that there was really no difference between groups when we talked about things like how many patients were occluded, how long the lesion length was, what the stenosis, the diameter stenosis was. And why am I showing you that? Because I don't want there to be an argument that one group was better than another, right? It's important to know that the comorbidities and the anatomy of these patients were essentially the same across groups. I mean, that's how you do a good randomized controlled trial, which is what was done here. And the Rutherford classifications, again, across the board were essentially similar. So talking about the primary endpoint, which was at 1 year, what was the angiographic stenosis? So I want to call your attention to this. This is a bit interesting, frankly, something that Boston does. I've not seen any other company do it. And I don't know if it's a naughty thing the company is doing or it's a good thing, but they get angiographic evidence of the stenosis. Most of the time, if you're doing one of these studies, you get an ultrasound, you get a duplex, right? These guys went the extra mile where patients were getting actual angios to identify the level of stenosis. So it's true stenosis is my point, right? The only thing extra that could have happened is IVUS, but that's a little bit too much, I think. And the point here is, as you can see very clearly on the core lab, the percentage diameter stenosis over 12 months was the least in the Eluvia arm, right? Which is the drug-coated stent, and the most in the bare metal stent. So if you're not going to use the drug-coated stent because for whatever reason, you don't believe in it, you think it's too expensive, at the bare minimum, use the drug-coated balloon. Because this was surprising, because you would think that the balloon would do the worst, regardless of the fact that it had drug, then the stent with drug. But actually, this is what came out, that if you put a bare metal stent in, at 1 year, you get significant diameter stenosis. Now, you can make a clinical argument. Does it matter? If I still heal my wound, if the patient still has enough flow. The problem is there's no way to know if that patient narrows down by 60%, if you're going to have enough flow to do what you need to do. Now you're doing a reintervention. Maybe the wound arrests, and at this point, the patient gets an amp. So it's a really big deal to just do the right procedure one time correctly and give the patient at least that 1 year. And why are we harping on about a year? Because there's data that has been published that says that in order for a patient, specifically with diabetes, to heal a wound, they need at least 200 days of good blood flow. So it's about a year, right? 200 days. So you really want your single intervention to do a good job, right? Now, that's all cool. Look at 2 years out, right? At 2 years out, you're still seeing benefit if you're using the drug-coated versus not. But once you get to the 5-year point, right, now you're starting to see no difference between groups. And the reason for that is because the drug wears off. At some point, your Eluvia stent is going to just be a bare metal stent. But at some point is 5 years down the line. Therefore, again, if you can get away with even one less intervention, you've done a great thing. Oh, excuse me. Sorry. One more slide before my conclusion. Just talking about the Rutherford classification. We have to do this. I know in real life, us day to day don't put the Rutherford in the chart, but really this is just a way of saying the wounds are healing, the rest pain is going away. That's really what we're saying here clinically. And I know there are a lot of the rainbows on the screen here, but the point that's really what we're really showing is that look at the difference as you move out. And this is an important point because look, there's no difference when you at 6 months, but there is a difference at 12 months. And why does that matter? That matters because again, historically, all of us, when we used to do studies in PAD, the end point was 6 months. That's what we used to talk about. Nowadays, you don't find a study which talks about 6 months. Nobody cares about 6 months. It's all about the duration, the 12 months, and sometimes even 24 to 36, because that's what matters, because you're trying to reduce amputation rates, reintervention rates, and increase wound healing rates. Not just say, oh, the stent was open at 6 months. Those days are gone. That actually is because of the FDA. The FDA has changed their own goalposts and said, we don't care about just the endpoint anymore. We want to know about whether or not the leg's attached to the patient's body and they've actually clinically had benefit. So in conclusion, all I'll say is that using drug-coated stents are better than using non-drug-coated stents, so bare metal stents, and better than using a drug-coated balloon. Do you have to put stents in everybody? Of course not. Of course not. But it's important to know this literature, to know that if you have a patient that you're concerned about, that you want at least a certain amount of time where they've got good, consistent flow. Because even if a patient's ABIs don't change, it doesn't mean that they're not reducing the amount of flow to a particular location. You want to be sure that whatever you did gives them the best chance of healing and having that great outcome. And that is clearly through a significant amount of data, not just the sports study. Sports was on the shoulders of a lot of other trials that have come before it, including stuff that Boston Scientific has done with registry and single arm, that said that we knew that when we did a study like this, we were going to get this result. Companies don't put this kind of money into stuff like this unless they kind of know that that's what's going to happen. And indeed, that's what happened. So it was a great study, very significant lesions, real world data, showing that this really does have a benefit if you use a drug-coated stent versus not. And with that, I'd love to take a couple of questions, and I'll hand it over to Dr. Schneider.
Very good. One thing just briefly from the chat, one of our colleagues is asking about your double wire technique, one wire going up, one wire going down. Maybe you could tell a little bit more detail about that so that others will know.
I'd love to. So I use this all the time. The residents hate it because it is pretty painful, but you get all the glory at the end, okay? Basically what you do is you do your femoral end art. So you're looking, and you got your clamps on, you're looking at the open end art. You take a CXI, I use a CXI crossing catheter. I use an 035, and I backload a V18 into that. And then I actually take the CXI and put it, if I'm going up into the iliac, put it into the femoral end art. I'm holding with my Gerald's the actual femoral artery up, so I know I'm in true lumen. That's why it's so beneficial, because you're in true lumen. And then I'll hold the CXI there and have the wire pushed from the back. and then move the CXI up. So it's barebacking it up, and you have the best chance of staying true lumen. Then I have that wire in. Then I turn my attention to the SFA. Exactly the same thing. Hold the SFA up with your Geralds. CXI, I use an 018 on this side typically. I'll put a V18 in again. Same sort of thing. Get it all the way down. Then I pull both wires and I shoot dye to confirm I'm intraluminal in the aorta, obviously through the iliac, and in the SFA through the SFA. Then I put the V18 wires back, take the CXIs out. And now what I do is I start to suture my patch. So I do the proximal part of the patch. And when I've sutured half the patch, I stick the patch as if I was going to stick it to actually access it. I've not actually, sutured it all the way. I'm holding it up. I stick it with the micropuncture needle, and then I backload the V18 through the micropuncture needle, right? And you'll always get a little bit of garbage, like the actual micropuncture will kind of shear a little bit of the V18. It just makes a little metal coil. Just pull the wire out, and basically that thing just comes off. And now you have it intraluminal into the aorta, coming out exactly where you're going to load your sheath to do your procedure, right? So you keep that wire there, and then you do the exact same thing with the other wire. And now you have two wires that have come out of your patch, and then you finish your patch. But you have it in exactly the middle location, and you know that you're not going to lift those planes, right? Because again, gone are the days, right, where we have a nice chunky plaque right in the femoral that comes out. Nowadays, all of us have these pipes that come down from the iliac into the SFA continuously. So you really do need something that can ensure that you're intralumen, because nothing is worse than getting into a dissection plane once your patch is down.
Right. No, that sounds like quite an operation. So I'll go ahead, and then we'll have time to come back to your case. Pretty interesting case. That's a lot of operation that patient had. So hopefully he does really well. Those kind of ulcers like that one you showed, those people are in agony. But it's almost like arteritis. I mean, in the sense of how painful those can be just to touch the edge, etc. Anyway, so like you, I was super impressed with the sports trial data. And I was over at Charing Cross over in London when I know Sonia was there. And when Gunnar Tepe, who designed that trial, when he presented it, and Gunnar Tepe is a friend. He's an interventional radiologist from Rosenheim, Germany, and he and I had been co-PIs on a couple of trials in the past. And so I reached out to Gunnar and to ask him about the sports trial. I was really impressed with it. So we got to talking, and he sent me a case, which I thought was pretty cool. Because this idea about the 1-year angio, it's not something that we can do freely here in the US, but in the EU, they're able to, not for every patient, but I think it's more readily possible than it is for us. So this is his case, 65-year-old man, bilateral lower extremity claudication, quite severe, left side worse than right, diabetes, history of smoking, but the patient had quit. And you can see the patient has long SFA occlusions on both sides. I'm not surprised that the left side is worse, because you can see the patient has more profunda disease on the left side. And of course, that's what the patient is limited to in terms of flow, is through the profunda. So the left leg, so the patient was entered into the sports trial. The patient randomized to the Eluvia stent arm. So it's a 3-arm 1-to-1-to-1 randomization, as you saw from Anahita. And this was the runoff. You can see an above the knee reconstitution in this area here. Still a fairly diseased distal SFA and proximal pop. Patient has 2-vessel runoff. And this is the result after Eluvia stent placement with, at the time, they felt an excellent technical result. You can see they carried the stent down to the junction of P1, P2, I think because that P1 segment was so diseased. The patient in follow-up had improved left leg symptoms, but the right leg continued to limit the patient. And it just shows the what the right leg looked like. Again, almost as bad, but the profunda wasn't quite as diseased, a long segment occlusion. In that patient, they proceeded with DCB plus spot stenting and got a good result. And this was the 1-year angio. I thought looked excellent on both sides. The Eluvia side on the left, the DCB side on the right. Again, the sports trial I thought was really unusual and really interesting. And that was why I reached out to Gunnar. And like I said, he's quite innovative guy. He was the one who authored the Thunder trial, which was the first major FemPop DCB trial. It was published in the New England Journal in 2008. And really the trial that I looked at that got me convinced that DCB was going to be worth looking into. And of course, it wasn't until about 3-4 years later that we had approved FemPop DCBs in the US. But what he was aiming at with the sports trial was this concept of not so much a device-to-device comparison, but an algorithm comparison. So, and you saw what the baricitinol versus DCB versus DES. So I thought that was pretty cool. And like I said, I saw that data presented when he first presented it, and then the follow-on presentation I'm going to show you now, which was by Andrew Holden, equally as impressive. So this is a meta-analysis of stenting in the FemPop segment, or different types of stents in the FemPop segment. But I'll just show you here what the Eluvia data looks like. Sonia indicated some of this, but you can see in the blue at the top of the field that when you rank the primary patency versus lesion length, you can see that it's not necessarily a downgoing arrow the way it is in the gray arrow below, which shows bare metal stents, that there's a potential diminishment in patency as the lesion gets longer. So the data I wanted to present, again, this comes from Andrew Holden. So one of the benefits of this webinar, if you will, is that most of this data was generated outside the U.S., not the Truveta, but this study and the sports trial. So it's nice to kind of get a chance to get a fresh look at it. So this is run by the Prospero protocol, if you will, a systematic literature review and meta-analysis, including both long and short lesions. And I'll show you what that looks like. So it started out with 870 articles, ended up with 142 articles and 52,000 plus patients. A little over a quarter were core lab adjudicated, and about 2/3 met the assessment of fair or better quality. And these are the results. And what you see on the left-hand side is the polymer-based paclitaxel-eluting stents, polymer-free paclitaxel-coated stents, covered stents, and self-expanding nitinol stents. And what you see here is the 12 and 24-month primary patency. So the 12-month patency was 87% for the polymer-based paclitaxel-eluting stent. So that's Eluvia. And then 76, 75, and 75 for the three others, the polymer-free, the covered, and the self-expanding nitinol. You can see a similar pattern. Each type of stent loses a little bit of the patency benefit, but between 12 and 24 months. But you can see the polymer-based paclitaxel-eluting stent at 77.9% patency at 24 months. And this is the division into short and long lesions. So lesions less than 150 millimeters, 15 centimeters. You can see the polymer-based 86%, polymer-free 83%. There were no covered stents in that short lesion category. We know that the studies that have been done with covered stents are typically in the range of 17 to 20 centimeters. So I'll get to that in the long lesion category. And the self-expanding nitinol stent, of course, is the lowest. Then with regards to longer lesions over 150 millimeters or task C and D, you see 87% for the polymer-based at 12 months with the longer lesions, 70% or 70.7 with polymer-free, 75.9 with covered, and 72 with self-expanding nitinol stents. So there is a fall off. And then at the 24-month time point, 79.7 for the polymer-based paclitaxel-eluting stent, 72 for polymer-free, and 69.9 for self-expanding nitinol. And then the longer lesions, 77.8, 60.1. So I think at this point, after seeing this data, you realize there's some seeming predictability to it. And this is the repeat revascularization or target lesion revascularization at 12 and 24 months, 7.3% with the polymer-based Eluvia, and 13% with polymer-free Zilver, covered stent 18.9, and self-expanding nitinol 14.3, and then a little bit of a drop-off or an, let's say, increase in repeat revascularizations with each of those at 24 months. And then mortality, this comes up, maybe we have a couple minutes to discuss it, but the mortality was not significantly different. Really, all of the results overlapped at both 12 and 24 months with respect to the confidence intervals. And you can see the self-expanding nitinol and the covered, of course, are not paclitaxel based. And you can see that they were right in there and consistent with the 2 to 4 or 2 to 5% we saw for paclitaxel. And then the highest then with the 24-month was actually in the covered stent. So, we know this has been a topic of conversation, but nevertheless, the results here, this meta-analysis, were relatively consistent, differentiated the patency of the polymer-based drug-eluting stent at both 12 and 24 months, and especially for longer lesions. So maybe I'll stop there. We have a couple more minutes for discussion. I'm wondering, maybe Sonia and Anahita, maybe you can help me with this issue of the paclitaxel. I don't know what your sense is about it. My 2 cents is that patency in the FemPop segment is at a pretty high bar compared to everything else that we have, both drug-eluting stents and drug-coated balloons. And of course, we saw the results of the sports trial, so it's not quite so simple. We can't lump all of the paclitaxel drug-coated balloons all together. There's some differences. But I don't know, what are you thinking, Sonia, about paclitaxel in your practice?
When that Katsanas paper came out, obviously it took everybody a little bit by surprise. And I think all of us kind of retreated from drug elution because, we wanted to make sure we could, safely do these procedures on patients and not obviously have an increase in mortality. But, you look at the TRUE-PTX, which is, 10,000 patients is what we looked at, but huge databases. You're looking at what you presented globally, a lot of paclitaxel-based technologies. And we're really not seeing the mortality signal that we saw. I feel very comfortable using paclitaxel on patients. It's going to be interesting to see what sirolimus does. I mean, that is a new emerging technology, and we want to do the best for our patients. So I'm waiting to see what that shows. But as you said, the results currently with paclitaxel, both in drug-eluting platform as well as drug-coated balloon platform. So if it's a smaller vessel or in coordination with intraarterial lithotripsy, it'll be interesting to see how it stands up and how it does in the tibial vessels. But I'm encouraged. I don't think that stops me from using paclitaxel in the periphery. What about you, Anahita?
It never stopped me. Honestly, I mean, this is an even different take than, the mortality issue with these patients that have like critical limb-threatening ischemia. We don't talk enough about the fact that their life expectancy already is sometimes 2 to 5 years. So if I can get them to not have 5 interventions over the next 2 years that they're going to be alive, that's the way to go. And ultimately, that is what ended up being the signal. Like, these are just really sick people. And it never was the drug. It was that they're, again, just ill. And, it's like a cancer. And ultimately, people on a continuum, you keep their leg attached. They do okay. And someday they pass away from PAD, right? Bad PAD. And so The big question is not so much no or yes to drug. It's really if sirolimus maybe is going to be different or better. I think that's the real question. Most people have put to sleep the idea that any drug is, the drug is bad and is going to have a mortality aspect to it. But what will be fascinating is if sirolimus in the tibials makes a difference. Our own Boston Scientific colleagues, they did the Saval study, which did not show the difference, obviously. But if we go back to why that happened, I think it's what I said earlier in the talk about the 6 months versus 12 months. The endpoint was not appropriate, and potentially had it been a longer endpoint or something of that nature, we would have seen a difference. And so I'm sure people will learn from that. And as the new studies come out, I bet that we will see, because it doesn't make any sense. Why would it be the case that it works for the heart and it works for the SFA and it won't work for the tibials? It's just illogical.
Yeah, obviously we have a lot more to learn, but I have felt for a while and continue to believe that the drug delivery for the lower extremity is here to stay. Even though we're still working on it. In any event, just a couple of quick things in closing. One is that, like I said, I got to see a lot of this data presented outside the US. So one of the values of a webinar like this is getting a chance to kind of go over it one more time. It was an honor for me to get a case from Gunnar Tepe, who I think is a kind of a visionary in this area. Usually when you design a randomized trial with 3 arms and fewer than 100 people in each arm, to get a really clear-cut result like that is fantastic. It means that they were careful about how they designed it. And also the idea of a 12-month angio is also terrific, because it's not something that we can easily do here. And then lastly, I think it's, like I said, it's really fun to review the cases. I mean, my main question is, I want to know what Anahita's son thinks of all these cases. Because
He's busy trying to put clothes on. I'm sorry, I don't know how much you saw. The wild animal.
we didn't see a thing. We just want you to know that
then he'll be
everyone's
back 'cause he
welcome.
wants you to see it.
Yeah, everyone is welcome. But just in closing, just wanted to give a thank you to, I think, Boston. Great. Really appreciate that you sponsored this and got, a little bit more exposure to this information. But also the SVS Foundation and Catherine Lampy, really appreciate that. I think these kind of partnerships to facilitate it and to make it a little bit more user-friendly, et cetera. I think that's really important. So anyways, any closing and anything else, Anahita or Sonia, that I left out?
No, thank you very much for your time. Thank you, Boston, for putting this on, and I appreciate everyone taking the time in the evening to come and learn about this.
Yeah, thank you all for joining us. Thank you, SVS and Boston Scientific, and thank you, my co-hosts. This was really fantastic. Thank you so much.
Super. All right. Hope you guys get to take the rest of the day off. Anahita, you got more duty, I can see.
Okay. Both ways, duty and duty.
All right. There you go. Bye-bye.
Good night.